Donc, on est très, très heureux aujourd'hui d'accueillir le professeur Brendon Stubbs, qui est un des stars internationales dans le domaine de tout ce qui est exercice physique et maladie mentale, à la fois sur le plan de la mesure et du suivi de l'activité physique de nos patients, mais aussi sur le plan des interventions. Et vous savez, comme ce sujet fait partie des facteurs de risque environnementaux, mais aussi des pistes d'amélioration du pronostic de nos patients. Il travaille dans le très grand institut de psychiatrie de Londres, au King's College, que vous connaissez tous. Et donc, il a accepté de faire cette conférence, ce dont on le remercie beaucoup. Alors, on a beaucoup de discutants et de présidents aujourd'hui, parce qu'on était plusieurs à ne pas savoir si on pourrait être là. Donc, on a aujourd'hui la chance d'avoir avec nous le docteur Nicolas Bayle, qui travaille à 2 mètres du centre expert schizophrénie de Chenevier et qui est spécialiste donc de rééducation, surtout pour les patients atteints de maladies neurologiques, mais qui du coup va s'intéresser aussi à nos malades. Donc, on est très heureux de l'accueillir. Et puis, on a comme président Andrei Szoke, que vous connaissez tous. Et je vais tout de suite, si vous en êtes d'accord, donner la parole à Brendon Stubbs.
It's really very good to be here today. Thank you for the kind invitation to talk to you. Thank you for taking time to listen to some of the evidence and the research and some of my sort of findings on clinical practice, which I'd like to discuss with you today. I'm really looking forward to spending this time with you, and I really welcome your questions towards the end of the talk. We're going to have a set time for questions. And it's just a real privilege to be here. So thank you to the foundation and to Marianne for the invitation. And I'm really, really pleased and thrilled to be here. So I'm a physiotherapist and I'm also an academic at King's College London. And my research really focuses on the physical mental health interface of people with mental illness diagnosis, particularly people with serious mental illness, and particularly the role of physical activity for the promotion of better well-being and as a management strategy for the physical and mental health of people with mental disorders across the age span from youth to people who are older. And what would I like to talk to you today about? So there's 3 key areas which I wanted to talk about. Really look at the evidence base around how integrated and important physical health and medical speciality and specialism is so entwined and so important within psychiatry and psychology and people with severe and enduring mental illness. And then look at what's the relationship between physical activity and movement as a potential risk factor for the onset of mental health symptoms and disorders, and also used as a strategy, as an intervention. And just to also then look at what does the evidence base say about interventions for physical activity, exercise to improve people's mental health and physical health with severe and enduring mental ill health diagnosis. Just to say, I'm funded by the government in the UK on an advanced fellowship. So this is a government organisation. I've written numerous guidelines and books on this particular topic. I've supervised PhD students in the area. So it's fair to say that, I'm invested in this area personally. So it's an area of, great interest to me, and view the evidence and what I present with an element of white hat bias. But I will stick to the data, but just to say that this is part of my role, so I'll stick to the data. So we've known this for all of people who've been working clinically for a long period of time, and we brought all of the evidence base together in a Lancet commission in 2019. And really, this is a very huge document. For anyone who's done a Lancet commission, you'll know these are huge pieces of work. And really, we set out to draw a line in the sand and say, what is the state of medical and physical health conditions, comorbidities and services and gaps in people that have a mental illness diagnosis? How can we better integrate care and services? What are the gaps, and what is the role of lifestyle and optimal interventions to address this issue? And this was a piece done by people all over the world. We work with physicians, we work with people living with schizophrenia, we work with psychologists, physiotherapists, sports scientists, dietitians, psychologists, geriatricians, neuroimagers. So a real broad range of people, and also carers of people with severe mental illness. And this is really just to draw a line in the sand and say, where are we now? What are the gaps, and what can we do about this? And this is the foundation of everything what we're doing to bring integrated services to protect the physical health and whole person health of people with mental illness diagnoses. And we're really concerned about the physical health, particularly of people with severe mental illness, for lots of reasons. But this is one reason we're really concerned. And this is not particularly new, but this figure that displays the issue really well of the scandal of premature mortality. And this is average age of life expectancy of people in the Danish National Registry. So you'll be aware in Denmark, they have great data on people life expectancy. And this is a 30-year time period from 1980 to 2010. And in this red line here, going nicely up over time, you can see an increase of life expectancy of females in the general population and males in the general population too. So over this 30-year time period, people are benefiting from advances in living standards, housing conditions, better quality of and access to medical care, public health policies, etc., etc. But we don't see the same issue when we look at the whole population of people with schizophrenia. We see a bit of jumping around, but overall we see this gap reducing. And this is females with schizophrenia, and this gap is widening, and males with schizophrenia. And this is the gap in premature mortality between people with a diagnosis of schizophrenia and matched controls without schizophrenia. And we are really concerned about this, and it equates to 15 to 20 years of life lost, not putting into effect all of the years lived with disability that may precede that before someone dies early. And an abundance of research has shown that the large majority of this is due to physical health comorbidity. And previously, and for a long period of time, well, since I've been working in mental health services for 20 years at least, and I'm aware it's been going on for much longer than that, Henry Maudsley at my hospital wrote about this over 100 years ago, the importance of physical health. And now it's starting to get traction in mainstream media. So the New York Times covered this relatively recently, saying that people with serious mental illness are dying 50 to 30 years earlier than those people without. So it's not just healthcare professionals, psychologists, psychiatrists, physicians, physiotherapists, people with illness that are worried about this, but this is starting to make mainstream news too. And as I mentioned, we know that a lot of these deaths, approximately 70%, are actually due to the increased prevalence and incidence of physical comorbidities. And one of the primary things we've been concerned about, amongst many others, is cardiovascular disease and the cluster of cardiovascular disease. And we published this in World Psychiatry a few years ago now, looking at all of the data. And we showed that if you had depressive disorder, bipolar disorder, or schizophrenia, you're much more likely to have cardiovascular disease. If you don't have cardiovascular disease compared to controls, you're much more likely to develop cardiovascular disease. And if you do develop cardiovascular disease, you're much more likely to die from this too. And we published a paper in the American Journal of Psychiatry last year looking at screening and interventions for cardiovascular disease in people with severe mental illness, and demonstrated that people are much less likely to have investigations and prescriptions for the treatment and management of cardiovascular disease. We've published papers in Lancet Psychiatry and others showing we see a similar thing in cancer, where we see this reduced screening and active intervention for people with severe mental illness. So physical comorbidities are a real issue at a much younger age. But as you will know from working clinically, often physical conditions and comorbidities don't come in nice silos where you get one condition. And people often have, one or more condition at any one particular time. And healthcare systems, certainly in the UK, are very much set up to look after you in a cardiovascular pathway, or look in your respiratory pathway, or a diabetes clinic, for instance, or let's look at an osteoporosis clinic. But people present with complex clusters of physical health multimorbidity, so two or more clusters of conditions of physical health disorders, which happens much more commonly in older people in the general population, but we've shown recently and increasingly that this is happening much younger in people with psychosis. So this is paper from the World Health Survey showing that in people 18 to 44, we've got this greatly increased odds, so 2.5 and 4.5 times increased risk of physical health multimorbidity compared to matched controls, which is higher than older people with psychosis versus their peers. So we've it looks like this ticking time bomb of people who have earlier serious mental illness and have many physical comorbidities. And this is going to present increasing challenges for health systems and medical, physical, and psychiatric specialities working together to address this ever, complex presentation which people have. And we looked at this in our local electronic health records in South London across 5 boroughs, and almost 10,000 people with schizophrenia between 2013 and 2017. And we wanted to understand, two primary things: how many people with schizophrenia spectrum disorder had physical multimorbidity, i.e. 2 or more physical health conditions. And these are people with a mean age of 40, mid-40s. And we wanted to understand how many died and what were the top 5 population attribution fractions for 5-year mortality. And we looked at this at a systems level, and we found that, broadly speaking, we had clusters of cardiovascular and respiratory disease, neurological and respiratory disease, and respiratory and skin problems, and endocrine and respiratory problems, and respiratory and digestive issues, were accounting for the largest proportions of these early deaths in people with schizophrenia, and 2/3 had physical multimorbidity in their mid to early 40s. So this, is an issue much younger in our cohort. And we published this paper in Acta Psychiatrica using the Danish National Registry. And we wanted to understand, is this something we see and can replicate in big, robust data? And we found a similar thing, that people with schizophrenia, you can see these hazard ratios for mortality here. As you add on the number of physical health conditions from 1 to 2 to 3 to 4 to 5, you see this really, really quite scary, big confidence intervals, but increased risk of early death in people with schizophrenia. And you see a similar thing in the general population as you'd expect, but the effects are not quite as profound. So physical health lack of integration is really, really important. We need to work together. The presentations are becoming increasingly more complex and not isolated to individual disease mechanisms. And there are numerous factors which contribute to difficulty identifying and managing physical health conditions in people with severe mental illness, such as changes in perception of pain, potential diagnostic overshadowing, and many health, structural and social systems which make it difficult for people to access services. So moving on to why may physical activity and exercise be helpful in this context? So what may the benefits be of physical activity and exercise? And is this just a nice thing to do and consider because it would be, good to do, or is there good evidence to say that there is some robust science behind this? Many of you may have heard of John Ioannidis, who is a professor at Stanford of evidence-based medicine, who's done the most downloaded research paper of any discipline of all time, whether it be physics, chemistry, medicine. And he did the paper, why most published findings are false. And he's very much in terms of looking at credibility of evidence. And John did this great paper in the BMJ about a decade ago now to understand a simple question in the general population. When you compare physical activity and exercise versus common pharmacological treatments for cardiovascular disease in a general population, what's better to prevent death and cardiovascular disease? Exercise, physical activity, or drugs, or are they similar? And this is a leading cause of death in people with severe mental illness. And what John found is, broadly speaking, whether you're looking at coronary heart disease, stroke, heart disease, pre-diabetes, exercise was, as effective as, statins, beta blockers, ACE inhibitors, these common medications which will prescribe people and broadly as effective. And there are numerous network meta-analyses which have been published now looking at various factors such as hypertension and comparing exercise versus these pharmacological interventions, and showing, again, broadly in line with the meta-epidemiological evidence that exercise is good. So this is our anchor point. If we want equity of care for people with severe mental illness, the research is saying that physical activity can be just as effective and helpful to prevent the leading cause of death in people with severe mental illness. So, but also not just looking at mortality, this is data taken from the Lancet Global Burden of Disease. So how does it affect people living their lives? And if we look at what are some of the risk factors, this is UK specific, but there's other data looking at, across the world, and it's broadly replicated. So, understandably, if we look at, external factors or behaviors or markers which we may be able to modify, what's contributing to years lived with sort of disability, and understandably, tobacco smoking is top there in terms of the burden on the population. High blood pressure, high body mass index. I think we all recognize just how important this is, very intertwined with, other factors such as physical activity, social environment, nutritional intake. But what we see also is physical activity or inactivity is the fourth rated important risk factor, which we can do something about to influence the global burden of disease. And there's other factors down, alcohol use as well, which again, I don't need to tell you how important that is, diet, etc. So this is just to place the importance of how much physical activity is beneficial in the population and its potential. And perhaps unsurprisingly, when we look at this in people with severe mental illness, we find consistently that people with schizophrenia, bipolar disorder, and major depression engage in much lower levels of physical activity. Over 50% are less likely to meet recommended guidelines of 150 minutes of moderate and vigorous physical activity. So we've got much more to do to help this population when we consider the earlier slides about what's contributing to early deaths, the potential role for physical activity. Yet here we see people are not doing very much. So we've got lots of opportunity. Now, what a bit about physical activity as a potential risk factor for some mental illness symptoms and disorders. So briefly, we looked at this recently in the American Journal of Psychiatry. Another dose-response meta-analysis came out by some other colleagues about a month ago in JAMA Psychiatry, which generally showed that higher levels of physical activity are, associated with the reduced risk or odds of depression in the future by around 20 to 30%. And this meta-analysis we did, and the new one in JAMA Psychiatry, found generally that the more people did, the better protection that was conferred against the development of depression in the future. I don't need to tell any of you just what a complex condition and heterogeneous condition depression or any mental illness is. This is not trying to distill any physical and mental illness down to one risk factor, but to highlight at a population level just how important physical activity could be as a risk factor in this context. And here is a paper we did in Lancet Psychiatry looking at young people with accelerometers. And what we found here is between the ages of 12 to 16 is in green on the bottom, we found consistently really low levels of moderate and vigorous physical activity. In the blue line, we saw increasing levels of sedentary behavior, and people who persistently engage in sedentary behavior, young people, were more likely to have depression in the future, and this decline in light activity too. And we calculated with some substitution and analysis that if you replicated an hour of light activity with sedentary behavior per day, you could by about 10% reduce the risk of depression in the future in this prospective cohort study. And we've also done this quite recently in the UK Biobank with a 7-year follow-up, and generally found that if you can replace some of the sedentary behavior with light or particularly moderate or vigorous physical activity, that you can reduce the risk of depression and anxiety in the future. And this was a paper we published in BMG Medicine recently. To provide some increasing their sturdiness to our findings, Carmel Choi and colleagues at Harvard have undertaken a number of Mendelian randomization studies, and they have found that there is, and I'm not going to go into Mendelian randomization studies, it's not my area of expertise, but I'm going to summarize the findings. They have found that there is a causal pathway between higher levels of objective device measured physical activity and the risk of depression in the future when you're looking at prospective cohort studies with their fancy analysis. And in another paper, they looked at 30,000 people who all had genetic increased predisposition to depression, and looked at their objective physical activity levels and found that when you looked at those who engaged in higher levels of physical activity compared to lower levels of physical activity in this homogeneous group of genetic predisposition to depression, genes did not determine the risk of depression in the future. People who were more active were less likely to have depression in the future, regardless of genetic predisposition, in a Mendelian randomization study. So this builds on this observational data from 260,000 plus when we did ours, to bigger meta-analyses more recently, and these Mendelian randomization studies showing this appears to be a strong association at population level. And just to say that we've shown a similar thing to suggest a protective role of movement in the protection of anxiety disorders and symptoms also for people too. I thought it'd be worth just to highlight an interesting couple of randomized controlled trials which have been done in young and healthy people. So here is a study where colleagues recruited people who are in the early 20s, no physical or mental health comorbidity. They were regular exercisers, and the PHQ-9 scores were measured, and they were randomized to the intervention group, who were advised to stop structured exercise for a week, and they were measured again at visit 2, and then carry on at visit 3 a week later, and the control group carried on exercising. And what this randomized control trial of 60 people in each arm suggests is that when you get people who are quote unquote healthy, regular exercisers, and you induce sedentary behavior and stop structured exercise, you see this reduction in or worsening in mental health symptoms. And Mark Hamer and Andrew Steptoe and colleagues did a similar thing again in young people who were free from any mental health and physical health comorbidity, were randomized to be more sedentary and not exercise, or continue with their amount of physical activity they were doing. And they found a similar thing, that if you induce all of a sudden sedentary behavior and stop structured exercise and physical activity, people started to become depressed, anxious, and they saw this inflammatory response, where there was this stress-induced increase in interleukin-6. I know we've got Marianne and experts here in immunopsychiatry who've done lots of work looking at just how important this is in the onset of depression and other conditions too. And this could be one of the mechanisms through which inactivity and sedentary behavior could be a pathway to the onset of mental health symptoms. And conversely, we know that exercise is a very good anti-inflammatory exercise in its own right, and reduces many inflammatory markers in the healthy population when we look at that. We've also looked at the issue of cardiorespiratory fitness, and is this related to the onset of depression and anxiety in the future? So not just about movement, physical activity is any bodily movement during the day, but how fit your heart and lungs are, and does this protect against depression in the future? And broadly speaking, we found here, and also in anxiety populations with prospective cohort studies, that people who have better or higher cardiorespiratory fitness are less likely to develop depression in the future, around 75% less likely compared to people who are less fit. And the good thing about cardiorespiratory fitness is this is quite malleable and is easier to change in a shorter time period than body mass index, for instance, or body weight. And body weight, as you'll know, is very difficult for all of us to change. It's very difficult for people who are receiving psychiatric medications and psychiatric care, and people can become quite despondent when this doesn't change. But we've shown that in the absence of change in body mass index or body weight in randomized controlled trials, you can get meaningful improvements in cardiorespiratory fitness in the absence of weight changes. And this is a better indicator and I've not got the data here, of a prediction of incident diabetes, incident cardiovascular disease, incident mortality, then body weight too. So we looked at in the biobank to understand, is there a difference between having a good heart and lungs, but also having strong muscles as well? Because we're increasingly recognizing that within physical activity, the World Health Organization guidelines recommend this. It's important to move. It's important to get your heart and lungs working, but it's also important to have 2 days where you're strengthening your muscles. That could be yoga or going to the gym or doing push-ups, that kind of thing. And is this good for protection against mental health going forwards, or is it better when they're both happen together? And what we found here is that both cardiorespiratory fitness and stronger muscles are protective against anxiety and depression in the future. But when you've got higher cardiorespiratory fitness and higher strength, this is, co-occurring better protection in the future. Hopefully you can understand the translation, and many of you have perhaps thought this as well. It's a common thing that I, get and talk to with people, and very understandable. One of the core tenets of having mental health symptoms, or not even having mental health symptoms or a disorder, is motivation is difficult. How do we initiate and how do we maintain physical activity and exercise? And this is one of the challenges with which we all face, and which we particularly face when this is such a core tenet and facet of people who are struggling with a mental illness diagnosis. And I'm not going to spend a lot of time talking about this, but I recognize it's a really important topic. But just to say, my colleague in Leuven, Davy van Kamfort, has done an abundance of work looking at the motivational frameworks for people with established psychosis, first episode psychosis, affective disorders, to say, how can we initiate initiate interest and action in terms of helping people to become physically active, and how do we maintain their motivation going forwards, and how do we use that? And there are numerous strategies which you can use to do that, goal setting and all of these behavioral sort of change techniques which we can use. But just to say, there is quite a bit of research doing this, and just how important it is to initiate physical activity. And I just want to acknowledge that too. So I realize I'm running out of time quite quickly, so I'm not going to spend too much time on this, but just talk a bit about the evidence from randomized controlled trials. And this is a slightly older randomized controlled trial and meta-analysis we did previously. And we demonstrated that exercise has a robust antidepressant effect in people with depressive symptoms or major depressive disorder. And one of the fair criticisms of exercise as an intervention for people with depression is that the trials were small, often less than 100 people, and had short follow-up, 3 months, 6 months. So Mats Hallgren in the British Journal of Psychiatry did a 3-armed randomized controlled trial with almost 1,000 people in, all with depression, living in the community, and people were randomized to treatment as usual, CBT delivered via the internet, or group-based exercise, and everybody had treatment as usual. And what Matt's found over 12 months with over 300 people in each arm is that both CBT and exercise over the same time period were equally and clinically and statistically as effective as each other, and better than treatment as usual in terms of reducing depressive symptoms. And when we think about some of the added benefits of physical activity and exercise in terms of cardiovascular disease prevention, management, etc., the potential benefits of exercise are profound. So large randomized controlled trial has shown that exercise has comparable effects to CBT in people with major depression over a 12-month period. I'm aware of a randomized controlled trial happening in the Netherlands at the moment, looking at people with depression. I've seen the abstract for the conference results. And this is done by a very credible team within the Netherlands, and they are comparing exercise versus antidepressants head to head, and running therapy specifically with mild to moderate depression. And what the initial results say, and I've only seen it at an abstract level and it's not peer reviewed yet and out in the public domain, is it seems that exercise and antidepressants for first episode depression were broadly as effective as each other, with less adverse events in and higher adherence in exercise. I will caveat that is not peer reviewed and published yet. It's only a conference presentation. It's done by a very, very credible team in the Netherlands, but the results will be out soon. And again, this is just to bring to the fore that exercise is not just a nice to have intervention. This is, the evidence is starting to build. This can have a really important role to play in physical health and mental health care. I'll go through these next few slides a bit quickly, but also to show that resistance or strength training exercises have been shown to also improve depressive symptoms. We have also looked at yoga as an intervention for people with different mental health symptoms. Generally, the quality of randomized controlled trials in yoga is not as good. The trial quality is quite poor, but there is also some evidence looking at other interventions such as Pilates. We recently published this paper in a British Journal of Sports Medicine looking at high intensity interval training. So this is where we're doing bouts of hard and fast exercise, followed by rest, followed by hard and fast exercise, followed by rest for sort of 30 seconds on, 30 seconds off. And the evidence suggests that this is, safe and effective and has comparable effects to continuous exercise. And there's quite a few randomized controlled trials in this context, and there's an emerging evidence base in people specifically with mental illness diagnosis, including schizophrenia and depression. We've also published a paper on that too. Just also to say, in young people, we see a similar thing, that exercise shows promise is in randomized controlled trials, in depression, in people at risk mental state for different mental disorders too. I'm not going to go too much into this in the interest of time. And we looked at what are the best rated pharmacological and non-pharmacological interventions to improve physical health outcomes in people with schizophrenia in world psychiatry. So we looked at factors such as metformin, some of the GLP-1 medications coming through, and we found that lifestyle interventions can have a large improvement on anthropometric measures and exercise interventions in people with schizophrenia too. There's some variability. This is based on meta-analyses and pooled data on the quality, but it goes to show that there is good evidence and it can be a viable option for people. I'm coming to the end of this now, but I'll sort of finish on this. We looked at all of the evidence base across mental and substance use disorders to over 150 trials, and just showed evidence from randomized controlled trials that exercise is very helpful to improve symptoms of depression, anxiety in children, adults, and older adults. It can improve mental health in people with schizophrenia, including people having first episode. There's some encouraging and early evidence in bipolar disorder, ADHD, and there's some caveats and considerations which we need in the context of eating disorders too. So where are we with guidelines? So myself and other colleagues, many of whom you may recognize, have recently looked at all of the evidence to say what is the evidence base for physical activity and exercise in people with severe mental illness. We work with the European Psychiatric Association and made a position statement and recommendations that physical activity and exercise should be, offered as part of a menu of options for people with mental illness diagnosis to help with physical health, mental health, well-being, functioning, and that people should be asked about physical activity as a vital sign in clinical practice. We've developed a tool called the SIMPAC in people with mental illness, which I can send to afterwards. And those are some of the key takeaways from this position statement we made. Getting on to the sort of take-home messages, I mean, really, the optimal exercise or physical activity program should be, whatever interests that individual person. Often when I'm working in clinical practice, I don't talk about exercise. I talk about the benefits of movement or being physically active, which we define as any bodily movement which increases energy expenditure. Certainly many people who I speak to I may talk to them about exercise and they may have conceptions about, school PE and think, I'm not going to exercise. I can't do that. It involves going to the gym, for instance, or playing football or playing netball, and really we're talking about any bodily movement which you can do, which you find fun and is going to get you moving. That could be playing tennis, that could be walking briskly, that could be yoga, that could be going to the gym, that could be dancing. It's all about finding a movement which you're going to enjoy and find pleasurable and you can do and you feel competent to do, because then you're much more likely to initiate it and then maintain it. And if you tell me, for instance, that I need to dance as my exercise for the next week, I'm not going to do any. But if you give me, because I can't dance, I'll look stupid and I won't want to do it. But if you say to me, Brendon, you can go out and go for a run and go to the gym today and that will count for you, and I'll be like, great. And then if you just say, it doesn't need to be 60 minutes today, if you just try 5 minutes of where you are at the moment, that's a really good start. That's going to motivate me because I think, wow, all I need is just to get going, is just to do 5 minutes. Those are some of the important conversations which I have with people. It's great to go up to some of the guidelines, but getting people started and really lowering the barrier of entry is really, really important. The evidence does suggest that aerobic exercise is good. So is resistance and HIIT training, and having supervision is a good thing too. If anybody, you're all busy clinicians, if you're stuck for time, this is a really good resource based on a motivational interviewing framework. It's free to use and download. And it's based on a 1-minute conversation with the patient, a 5-minute conversation, depending on how long you've got, or a more minutes conversation. And it's a motivational framework, free, moving medicine, this resource. And it's just about asking about exercise and physical activity, giving permission, exploring benefits. And it's a really nice framework to have a very brief conversation with people. And this is really the penultimate slide, touch upon mechanisms. This applies really across all disorders, whether it's schizophrenia, where we know even less, bipolar disorder, we know even less. A lot of it is theoretical based on laboratory models, but we probably have a better understanding in the context of depression. And we brought this together in neuroscience and biobehavioral reviews as best as we could quite recently. One of the common mechanisms which has been perpetuated in the exercise field is that the runner's high is due to endorphin release, and increasing research recently has shown that yes, endorphins are secreted when we exercise, but on their own they have difficulty crossing the blood-brain barrier on their own and exerting their effect. And it's very reductionist of us just to consider that any, positive feeling in terms of our mental health and well-being is due to one particular molecule or one particular mechanism, particularly when we're increasingly skeptical about the ability of endorphins, and beta endorphins to cross the blood-brain barrier. And looking at the literature we've done in terms of neuroimaging and inflammatory markers, oxidative stress, we believe that it's a multi-system neurobiological and immunological response. We've shown short-term changes in stimulation of hippocampus and prefrontal cortex. We've shown in randomized controlled trials volumetric changes in these key areas in children and adults. We've also shown in randomized controlled trials increased release of BDNF and changes in important inflammatory markers. We've shown greater HPA regulation, changes in cortisol activity, many other factors which we're just starting to understand in mental illness, mental disorders, including stimulation of the endocannabinoid system. But of course, there are other psychosocial mechanisms too. Let's not forget that if you go out and you go and do a walk, or you go and dance, or you go to the gym, you feel good. You've done something. Your self-esteem feels better. You may go and connect with nature, talk to somebody else. You feel a sense of social connection. You've achieved a goal. Your self-efficacy increases, and all of these psychosocial factors come into play too. And we believe it's a mixture of all of these and other unknown factors which count towards why exercise and physical activity protects our mental health and improves our mental health in the future. And we've got much more to do to understand this. So hopefully, through the conversation of this talk, you'll all be with me that this will not be the case going forwards, that it will be not who's going to be seen first. Is it going to be our mental health and our head that's going to be seen first, but very much, considering the body with which we're attached, and we're going to move away from this great separation. And my take-home messages are that movement is good for our physical and mental health. Being consistently inactive is not good for our physical and mental health. Working on just increasing our daily activity by small amounts can help us in our mental health, as can getting our heart and lungs going, increasing our strength. And when it comes to physical activity and exercise prescription, I take an approach which is very much based on the evidence, which is find a movement that you or the people you work with enjoy, and you're much more likely to do it, particularly if you can do it, and sustain it in the long term. And that would be a key message which I would send going forwards. Hopefully the data has convinced you that physical activity and exercise is not just some nice to have luxury add-on, but there is real value to improve the physical and mental health of yourselves and also the people that you work with. I'll stop sharing that. And I know there's been a couple of questions in the chat, but thank you for listening.
We are now, I think, all convinced that physical activity is very important for all of our patients. So we have two questions for now. The first one says that in the studies you conducted, did you consider nutritional aspects in your analysis, because subjects who fail to perform regularly daily physical activity are less prone to have healthy diet habits?
Thank you. That's a very good question. So as with many things, when we look at lifestyle behaviors, we tend to find that these cluster together. So, and they also tend to change together too, particularly if you focus on doing one well together. So if somebody is not very active, then it's highly likely that they'll cluster, that they may be more prone to not having as good nutritional intake. And it's highly likely that, or increasingly likely, that they may be more likely to be a smoker. for instance, and may have, you know, higher alcohol intake. So these types of healthy or unhealthy behaviors tend to cluster together. But what we see within our studies and trials as we account for these, and we always measure these, is that when you start to change and focus on one and do it well, so as increasing physical activity, and we've got a program going at the moment, is people start to become interested in, I would really like to start eating better. You know, what can I do to eat better? And now I'm moving and feeling motivated. I'd also like to stop smoking, or I'd also like to, do something about my drinking. So we see these factors cluster together. We adjust for those in trials, but when one starts to change well, we see interest in changing the other behaviors too. And I think it's important to note that.
Yes, totally agree with you. And another question I ask you, do you have any figures about what is better, regular exercise during all the day or one session of intensive exercises during the day? Exercises all along days depend, no matter what kind of exercises, or just one session of very strict program of exercises. What do you do with your patients for that? That's a really great question for all patients.
It's a very good question. So the data in people with, psychiatric diagnosis is not clear. And it's not clear in the general population. But what I tend to encourage people working with clinically is to do whatever they're able. Whenever I talk with patients, I'm encouraging them to be less sedentary throughout the day, and just to try and get up and walk and move every hour, just for a little bit of walk, get some fresh air, so they're continually moving and getting their heart moving, and moving the blood flow in their peripheries. And if that works for people, that they're able to do half an hour at lunch or a set time and they schedule it, then I think that's absolutely great. If that's difficult for people and they'd like to break it down into 5-minute slots over the course of the day, I think that's equally good too. But in an ideal world, it would be great to have a chunk of time in the day, and then throughout the course of the day, not just sort of be sitting there for the rest of the day at home watching sort of TV and not doing anything, but just every hour, just continue to sort of get up and move, make a cup of tea, go to the bathroom. So we're continuing to move and get the blood and heart going.
Yeah, I quite agree with you. And I think one of your key message was just find an activity you like and keep doing it. And the main difficulty with our patient, and that's the same thing with a neurologically impaired patient, Parkinsonian patient, for example, is to maintain compliance on physical exercises along months. And maybe making a patient walk a time a day and every day the same hour and the same time is easier to maintain that activity for a long time. If you start working on the morning and then on the evening on another day, and then at midday, after 1, 2, 3 weeks, they will not do the exercises. So they have to move all day long to work, to do a lot of activities. But if you want them to have a program of exercises, I think it's better to prescribe orally and make the program at the same time each day or each week. That's the main way we maintain compliance over months for patients with neurological disorders. That might be the same things for psychological disorders, but that's the main problem with our patients, say how to make exercises for months.
I agree.
Well, any other questions, either in French or in English, that we can translate if you want?
If we have still some time, I wanted to ask Brendon if there are some subgroups of patients, not only based on diagnosis, but maybe on comorbid conditions or other traits that might benefit better from exercises than the rest of them.
Yeah, it's a great question. Thank you, Andrei. I can probably tell you which groups in reverse. I find it more difficult to engage in exercise. So what we tend to see based on the trial data is people who have higher, illness symptoms, whether that be negative, increased negative symptoms, increased cognitive impairment, increased sort of social isolation, increased physical comorbidity. These are the groups of people who often have difficulty initiating, starting, and maintaining exercise. But conversely, the people who would also, really benefit from engaging in exercise. So much like in many interventions, we tend to see people who perhaps would benefit the most, having difficulty getting going. So I think we really need to target and focus those groups. I didn't really mention about the cognitive benefits of exercise today in people with schizophrenia and other disorders too, and that's it's a core component of many, psychological disorders. But we've shown robust beneficial impacts for aerobic and strength exercise, for improvements in cognitive function across people with depression, across people with schizophrenia, including changes in sort of hippocampal volume and also differences in sort of white matter hyperintensities too.
Well, thank you very, very much, Brendon. It was a great session, very convincing, amazing set of publications. So I'm sure this will help to translate into everyday practice. And thank you very much for a large audience to have stayed connected for an hour. And I think can all applaud Brendon. And bye-bye. Have a nice afternoon.
Thank you.
Thank you.
Thank you. Thank you, Brendon. That was great.